I've been working with Billings Clinic since February 2022 in the pediatric endocrinology department. And before that, I was working in Salt Lake City, Utah at the primary children's diabetes clinic, endocrinology clinic. And I worked with them during about 11 years. And then before that, I've worked with University of Utah as a diabetes educator too, mostly with adults, no kids. And yeah, before that, I was just working as a nurse, and trying to get my master's in dietetics and becoming a registered dietitian. And before that, I was in Spain. So anyway, quite a bit of a background. Okay, so let's start. I'm gonna kind of going over what we do with the families when they are newly diagnosed, when the kids are newly diagnosed. So we see kids from different areas, kind of relatively close to Bozeman, around maybe an hour to 2 hours away from Bozeman, from maybe Townsend, West Yellowstone, Livingston, Three Forks, Butte, and there's also another diabetes education program in Great Falls. So the ones closer to that will probably go to Great Falls. So the families that we get, most of the time, they are coming from the pediatrician or the PCP, and that's the person that will diagnose the child with diabetes. And as soon as they diagnose a child, they will be calling us right away. We sometimes see them right at the same day, but sometimes we see them the following day. And the amount of education they get, if they're coming from the pediatrician or the urgent care, it's pretty much nothing. Then we get a bunch of families and kids that are coming from Bozeman Health Deaconess, and they do receive a comprehensive education because there is a diabetes educator there and in the hospital, inpatient. So they get all these, insulin injections, what diabetes is, carbohydrate counting, how to treat low and high blood sugars, etc. When the kids that are in DKA, they will stay 2 to 3 days at the hospital. So they will be referred to us right after they are discharged. But if they are not on DKA, we will see them just the day of the diagnosis or the day after. Sometimes the doctor that diagnoses them with diabetes, they will give them, they will prescribe just Lantus, just to keep them from DKA, and then the following day we will teach the rest of the information about the other type of insulin. So next. Okay. So the day we see them, the day they come to our clinic, it's going to be quite overwhelming for the families. They are really affected by the diagnosis. I do feel their pain, especially, moms can be really, really overwhelmed. And sometimes even they cry, and it really gets me because I'm also a mom. So I cannot even imagine my child had diabetes. So I try to empathize with the families and the parents and understand their feelings because they are going through a lot after the diagnosis. And that they will meet mostly with me. I will do a kind of 2 sessions of education that day. And right in the middle, they will see Dr. Siska, Margaret Siska, our endocrinologist. And the first day we do mostly survival skills. And we try to make it as simple as possible, although it's kind of hard because the whole thing is pretty complex, but just explaining what diabetes is, what insulin comes from, the types of insulin that the child will be getting, and where the insulin is injected, how is it stored, treatment of lows and highs, and how to monitor blood glucose. And we will do the prescriptions. We try to do the prescriptions right before they come. So when they come, they would bring all the medications, the glucose meter, and it's easier to explain everything because they will have hands-on on everything. They usually do their first shot, the first shot of short-acting insulin during the training, so that way they can really experience what that is. Okay, next. Oh, and then that Pink Panther, that's the book we give them. That's the book that we give them, although we don't really go over the Pink Panther book, but they have it as a resource. And if they have any questions, it's a more comprehensive book about diabetes. Yeah, it's not very thick, but yeah, that's what we give them. Okay, so most of the times we will put a sensor on. The same day, the first day they come, we would put a sensor on. The sensor is the best way to monitor glucose levels. It used to be the blood glucose monitor, but the sensor just gives a better understanding of what's going on, because it does, as you know, the sensor, it gives you a number with an arrow by the number indicating the direction of the blood glucose, and it has alarms. So the parents are really happy to have that. It gives them a lot of peace of mind, and knowing that if the blood glucose goes up or down, then they're going to know, because they're going to hear the alarm. We also explain to them the importance of when to trust the sensor reading and when not, so if the sensor is saying high, the word high or low, they should be double checking with the glucose meter, because there is not a number. So they have to double check with the glucose meter and see what it really is, the number is. Also, if there is not an arrow by the number, that means that they cannot trust the number either. The number should always come in the sensor with an arrow by the number indicating the direction of the glucose. And then if the symptoms are not matching what the sensor says, if the sensor says the child is high, but the child feels symptoms of low, we go by what the child feels. And we really emphasize these three, so they understand when they have to use the glucose meter. Yeah. Next. Another thing we explain is the difference between the meter and the sensor, because the glucose is read in different mediums. The glucose, blood glucose meter, you test on the finger. It's a finger prick, and it's in the blood. So that's the blood glucose at this time. You could say that it will be the most accurate, because you know the blood glucose at this moment. The sensor is reading the glucose in the interstitial fluid in the tissue, so it is about 10 to 15 minutes behind the real value. So when the parents get a little bit concerned because the sensor is saying something and the glucose meter says something else, we tell them that's normal. They will never coincide unless you are checking in the morning when the blood glucose hasn't really changed overnight that much, because the child is not eating overnight, So that's the only time when both the sensor and the glucose meter will coincide. Otherwise, there's going to be always a difference of 30 to 50 points between the sensor and the glucose meter. So we explain that. We teach families to dose only before meals, before breakfast, lunch, and dinner, not in between. Otherwise, there is the risk for low blood glucoses if they are dosing also. If the child is eating snacks in between breakfast and lunch and they dose again, the child is really at high risk for having a very low blood glucose. So we decided to make it simple and tell them only dose before breakfast, before lunch, and before dinner. And between meals, try to give very low carb snacks with just maybe 5 to 8 grams of carbs with some protein, fat, so you don't have to dose at all. For little kids that are, 3, 4, 5, 6 years old, and if they have an unpredictable unpredictable eating habits, then they will dose. We will allow them. We tell them to dose after because it's safer. Yeah. And then the goal is to teach to use the insulin in a safe way, and later on when they have a better in their understanding of diabetes and how the insulin works, we can teach them how they can do corrections for high blood sugars in a safe way, not just doing the shots before breakfast, lunch, and dinner. Okay, so a lot of families definitely experience a lot of peace of mind after coming for the appointment, and they receive all this information because they now have knowledge. They have more understanding of the disease, and they know they have support from us. So they leave the clinic feeling so much better. Yeah. And okay. So the second day, because we usually make an appointment the following day to go over other concepts that we couldn't cover the first day because it's just too much information. So the second day, we usually go over ketones and high blood sugars, how to manage sick days, and then some of the carb counting. I give them all the resources and everything in a packet, so they will have everything. But the second day, I will go over this because, yeah, definitely the first day is not feasible, and it's not. Oh, shit! Can you hear me? Oh, yeah. I don't know what happened. Suddenly, when it disappeared, everything disappeared. Okay. So the second day, we go over all that. These are some of the handouts that we give them. You can go next slide. And then about a week after the diagnosis, we meet with them again. The endocrinologist needs to do another assessment and see how they are doing after a week of diagnosis. I will also meet with them and do some education, answer any questions they may have. And sometimes I have to review some of the concepts because the first time they are so overwhelmed that sometimes they cannot process all the information is given at the first session of education. With families that live far away, we will do a telehealth appointment that day, so we don't have them come if they don't need to. Okay. And during this second follow-up appointment with the doctor, we also will do the school care plan. We will do the school care plan, and we will fax it to the school. And then this is a nice handout that you will see in the next slide. There is a QR code that takes you to this, but these are some important concepts that are that we want school nurses and teachers to have in mind about the child with diabetes. So the importance of understanding the needs of the child with diabetes, the importance of always carrying the something to treat the low blood glucose if the child is going to be away from the classroom. So this is important to plan ahead and understand this. If the child is not feeling well, is having a low blood sugar, the child needs to be accompanied to the nurse office. The child should never go alone because he's at danger of passing out during if he has a low. Then if there are parties because of somebody's birthday, there are ways to plan for that. It's good to talk to the parents and plan ahead so they can make decisions about how to deal with this, so the child doesn't feel excluded from these events. And then the teachers need to understand that the child is going to have highs and lows, and they need to be taken care of. The child needs to have accommodations. The child should use the bathroom whenever the child needs to go to the bathroom, because that's one of the side effects of high blood sugars or drink too. So that would be very important that teachers understand that. And then communicate, definitely, and talk to the parents. The parents really feel really at ease when they meet with the school staff, the school nurse, and the school teacher to talk about the new diagnosis, and then make plans from there. So everybody's on the same page, and they feel more at ease after making, talking to the school staff. Mm-hmm. Next. So these are some resources I was telling you about. This QR code will take you to some information that this was made for teachers, but I think it will be useful also for you nurses. And then I don't know if you know, but the American Diabetes Association has a wonderful resources for training school nurses to be able to deal well and cover the needs of the diabetes child at school. Mm-hmm.
I'm a general pediatrician. I actually live and work up in Maine, where I spend some of my time being a clinician and some of my time doing health services research and asking questions about how kids get care in rural places. Because Maine, although it's in many ways really different from Montana, has that in common. And I've been really lucky to do some collaborations with Montana Pediatrics because they're doing so much great work around getting care out to kids who are in rural places. And so that's how I come to be connected to this. And I just helped to do some of the analysis on this survey. I think we can go to the next slide. So this was the goal of the survey, I think, was sort of twofold. Part of it was to figure out, thanks. Part of it was to figure out the experiences of families right around the time of diagnosis and what kind of made transitioning to being a diabetes family easier and harder for them. And then part of it was to get a sense of their kind of ongoing care challenges and experiences. And so we had some questions around both of those things. The survey had some really concrete quantitative closed-ended questions like how many months have you had diabetes and things like that. And then it had some open-ended questions where it just asked things like what made things harder as you were getting used to diabetes? What made things easier as you were getting used to diabetes? And then at the end it said, what is your diabetes story? And people really talked a lot about their stories, and they shared a lot about what was really difficult for them. And then I'm working through it, kind of trying to compare the sorts of experiences they had to the sorts of things that have been reported of families with kids who have diabetes in other places, and trying to hone in on how the setting of Montana and rurality impacted people and seemed to change that experience. But we'll generally talk about kind of all the things that people said here and kind of running through everything we can flesh out about the survey. And I guess my hope, to reference the slide that I skipped over, sorry, Kate, is that this is just helpful context for you as you're encountering these kids who will have had hopefully some diabetes education, probably some experience before they re-enter the school environment, but may not have had very much, and may still be in a very raw state where they're getting used to a lot when you are coming in and supporting them in the early stages of diabetes. I think we can go on. Let's see. So depending on whether you count number of kids or number of families or number of respondents, because we had 2 parents, it's somewhere between 114 and 120 responses we had. They came from all over the state. The kind of barriers of care that they faced included things like traveling a long distance for emergency care, and some of them reported as far as 100 miles to get to an emergency room. Very few of them reported having a mental health clinician, despite a lot of them talking about lots of anxiety and other struggles that were very mental health related. And about a third of them talked about having diabetes-related hospital stays. Most of them, I think, were just one stay after diagnosis for something like DKA, but some of them had up to 10. And then most of them had internet access. Most of them said endocrinologist, you'll see. And fortunately, most of them also had access to a school nurse, about 75%. Let's go to the next slide. These were a bunch of different questions about the care they received. Almost all of them had a PCP, and as you'll see, every single one of them had some kind of diabetes specialized provider, which is good. We asked a lot about the distance that they traveled to get to a PCP, and I think the majority of them were pretty close to their PCP. Saw their PCP not very often. This is in the bottom left here, for diabetes-related things, which said to us most people really were getting their diabetes-related care from endocrinologists. And I think the most common interval in the upper right here that they saw their endocrinologist was quarterly, which is good because that's pretty consistent with recommendations. Most of them said there's kind of actually a big range in terms of how long it took to see their diabetes provider. Some, it was as many as more than a month. And I think that's most of what I wanted to highlight here. Oh, in terms of seeing a dietitian or nutritionist, a food expert, or seeing a mental health expert, a lot said never, which we weren't really able to untangle how many of those people would like to see one and didn't, and how many of them just felt like they didn't choose to see them. But I think both of those are things that I would ideally like to see more people plugged into on a regular basis. We could go to the next slide, Keith. I highlighted here the kind of middle responses. The median kid was diagnosed sometime in those elementary school ages. The most common place to be diagnosed was in an emergency room. And you can see that the majority of kids said the initial education or training happened inpatient or in a hospital. The ones that said other, as we looked into their free text answers, a lot of them was the situation where they got diagnosed in a hospital or an emergency room, and then they had to kind of pick up and drive to see an endocrinologist. And that was a difficult transition for people. And I think some of the quotes will probably flesh that out. If not, I'll flesh it out myself. And we asked just kind of what are the sources of information that you used or that you felt useful. You'll see the Pink Panther book showed up a lot in people's responses. A lot of people talked about online resources, like podcasts, like Facebook groups, other communities that they sought out, and then more traditional medical providers. I think we can go on. In terms of the technology that kids used, the majority in the top line here, the majority of kids in this survey were using an insulin pump. Almost all of them had a continuous glucose monitor, and then a little more than half of them had a closed loop system. And so I think that says less about kind of the status of all kids in Montana than it does about these kids. And one caveat, which I think we have to put onto all these results, is that these are the people who were plugged into organizations enough to know about our survey and who were passionate enough to respond to it. And so I suspect that there's a lot of kids in a lot of different situations that we're not capturing the experiences of, which is just a caveat I want to take into this, that you may have kids that you feel like don't get well described by this population, and probably need different services, and maybe that's something to talk about. Kids generally got a pump pretty quickly, less than 6 months, which I was actually kind of a little bit surprised at. And then a CGM also less than 6 months. And then a closed loop system more like 1 to 3 years after diagnosis. Most people in this survey said that they were either mostly or extremely comfortable with each of those technologies. And most people in the survey said that they were pretty comfortable with some of the kind of diabetes care questions that we asked. And many people said that it was easy to contact and communicate with their school nurses. And then almost all said that they had a school nurse, although a lot kind of fleshed that out in the free texts. So really rich comments, and there's no way that I can do justice to all the things that people said. This was kind of under the umbrella of what you remember as being challenging and scary and difficult. And just to summarize, what I saw is that people had a really traumatic experience of seeing their kid very ill, being poked and prodded, being told that their kid could have easily died if they hadn't made it in time. And so they're in this kind of really traumatic state. And at the same time, they're taking on this huge burden of managing a kid um, and trying to figure out all of the logistical details that they need to do to care for a kid and getting education, some kind of additional education in the hospital setting, or even a day later. And at the same time, they're also thinking far into the future about these big questions about, is my child's life changed forever? Is my child gonna survive into the future? And so it's just a lot of scary things about the recent past and the trauma there, and the present information they need to learn, and the future that they're trying to think about all the way through their kid's life. And now I'll be quiet and let you read some of these quotes for a second, because they're more powerful than what I can say. Maybe we can go on. When we asked about what was helpful, a lot of people had somebody who had really stepped in and helped comfort them in addition to educating them in the midst of kind of that really difficult situation that they were in. So they talked about the staff at the hospital. They talked about, a doctor who stepped in and explained things to them that they felt like they really needed to hear. But there was a number of them that said things like this quote kind of right in the middle: "There wasn't anything easy. It was just hard. There was nothing easy about it at all," which I totally understand. Some people felt like they really didn't get a lot of support at all. They didn't get an education. They didn't get what they needed in terms of that initial diagnosis period. And a lot of them, there's this kind of sense that a lot of people had that their life was changed forever, that they're going to lose their ability to be normal and live a normal life. And a good number of them had somebody in their life who told them that their kid could still do wonderful things, that their kid could still live a full life, and that their kid wasn't going to be defined by diabetes. And I think that's sort of defined by the second to last quote. And it's tricky because I think these kids have to know that these families have to know that they're going to have to work really hard to manage diabetes, and that they'll have to be paying close attention to the insulins, but they also have to know that their kid is still going to have a good and full life. And I think there's this delicate balance that people needed to hear in those early times, and sometimes they heard it from the right person. I think that's probably enough to look on the side. And then a lot had comments about school. We specifically asked, tell us about your reactions or lack of interactions with your school nurses. A lot of people had really positive things to say about their interaction with their school nurses. That their nurses really knew their kid well, that their nurses were super interactive. Many said that their nurses gave out cell phones and let them text them, and they were just in really good regular communication. A handful of them, I think, didn't jive or didn't trust or had bad experiences with their school nurses in terms of knowing how to manage their kids' diabetes. And so that popped out a handful of times. And then a lot of people worried about the fact that their nurses were in multiple places, that their nurses were sometimes around, and that was a really beautiful safety net, and that their nurses sometimes weren't because they were going from school to school to school, and parents felt like they had to be aware of that and step in and fill the gaps, or that their kid was kind of at risk at the times that the nurses were away. And that popped up in the very times. Just trying to think if there's anything else I really wanted to highlight. The only other thing that I guess I noticed pop out is that as people were feeling very alone and very scared and very overwhelmed, and they were kind of learning how to adjust to all of this, a lot of people talked about plugging into other parents and organizations. They talked about their kids going to camp and that being a super empowering thing, because then they could be leading and teaching and also being around a bunch of other kids who were similar to them. They talked about people in their community who they didn't even know had diabetes or had a kid with diabetes, reaching out to them and kind of showing them a lot. And so I felt like that was another big takeaway that I had, is that, as isolating as it is to have a kid who has a disease that not many people in your community have, as isolating as it can be to feel like you're always on as parents and you always have to be taking care of your kid because you might not trust a lot of other people around you, or there might not be a lot of people that know how to take care of your kids. It really, really mattered to people when they could be wrapped up into a diabetes community. And so I think if you've got a kid who's struggling, that would be another powerful thing to do for them, is connect them to the broader diabetes community in Montana, or even kind of the online one, which stretches on forever. I'd love to know your thoughts. I'd love to know what parts of this don't gel at all with what you've seen, because it may be that we're just not capturing kids that have a very different subset of experiences. And I hope that kind of adds some flavor that may be in the back of your head as you're seeing a kid who comes in with a new diagnosis. I haven't been to one of these meetings before, so I don't know what happens now, but I trust that Kate will help us.